Rahim, let's talk about schizophrenia. ये एक नज़म गज़ल है, एक किसी मेरा ख्याल है किसी बड़े शायर की, एक कतील शफाई की probably. So वादे हूर पर बैठाए. Sorry, क्या?
Screen is not visible. The slides are not visible.
Can you see them now? No.
Sir, slides visible नहीं है.
They work. Look, the sign there, Mano. New work A46.
Okay, let me share it again. I hope it will be visible. Okay, अब नजर आ रहा है? पहले मुझे किसी ने कहा था कि नजर आ रहा है. Then I started off with it.
पहले आ रहा था, फिर नहीं आ रहा था, अब आ रहा है.
अब आ रहा है. Okay, so let's start with it. So कतील शफाई की नज़म है, वादाए हूर पे बहलाए हुए लोग हैं हम, खाक बोलेंगे कि दफनाए हुए लोग हैं हम, हंसी आए भी तो हंसते हुए डर लगता है, जिंदगी यूं तेरे जख्म जख्माए हुए लोग हैं हम. The reason why I tried to start from this was that whenever we talk about schizophrenia and whenever we talk about the system, we always talk about the clinical diagnosis, and most of the time in exam situation, this is what is usually required. But again, if an examiner asks you any question related to the basics of schizophrenia and you don't know, it's a big disadvantage and you may be in trouble. So maybe you won't get a question from this presentation in the exam, but you are supposed to know everything in this presentation. So schizophrenia is a stress-related neurobiological disorder characterized by disturbance in the form and content of individuals' thoughts, perceptual processes, affect, and social instrumental role behavior. The pervasive impact of schizophrenia across perceptual, cognitive, emotional, and behavioral domains, as well as heterogeneity within those domains, require a multi-modal and comprehensive approach to the treatment and rehabilitation, which involves the individual and his or her environment. Unfortunately, a multi-dimensional and interactive model that includes stress vulnerability and protective factors best guides the types of intervention for treating and rehabilitating persons with schizophrenia, but this never happens in the real life situation. So most of the time we just make people take the medication. Some of the times people do get psychological help, but as far as the social help is concerned, this is unfortunate that this never happens in developing countries like Pakistan. Now, people criticize a lot about the various aspects of problems associated in the developed countries, but in developed countries, biopsychosocial model of healthcare for the people of schizophrenia is very much practiced. And back in Pakistan, we have some domains which are unfortunately not as good as they should be. Whenever we talk about the clinical features of schizophrenia, we talk about positive symptoms, which includes delusions and hallucinations. We talk about the functional impairments like work, school performance, interpersonal relationships, and self-care deterioration. We talk about negative symptoms, which includes, again, not autism, but this is an old thing, but affective flattening, avolition, social withdrawal, alogia. These are the negative symptoms. Then cognitive deficits, attention, memory, verbal fluency, executive functioning. Disorganization, which is inappropriate affect, disorganized behavior and thought disorder, and mood symptoms like depression, anxiety, OCD, aggression, hostility, and suicidality. These are all symptoms. Whenever we talk about prodromal symptoms, lots of studies have been conducted over the prodrome symptoms. which includes maybe before the onset of actual schizophrenia, some symptoms like anxiety, distractibility, some symptoms related to a person feeling strange, symbolization, mysterious thinking, profound withdrawal, isolation, rejection, paranoid thinking, like people start believing that because I have done this, so people are just talking about it and they want to harm me or harm my work or attitude or anything like that. So, preoccupation with the religion. This is unfortunately very tricky. Some people around the age of 20 are too much involved in religion. Well, there is a different context to it. Some people feel that this is okay, but of course, this could be a prodromal stage of schizophrenia. Then altered sexuality, preoccupation with homosexual themes, speech and language disturbances are common in prodromal stage. Phenomenology can be defined as the study of events or phenomena, either psychological or physical, by means of empathy and immaculate clinical observation, but without embellishing those events or phenomena with explanation of cause or function. To very precisely say it, that whenever we are talking about phenomenology, we have to see everything related and associated to the presentation. In psychiatry, phenomenology is the way of understanding and describing the psychological phenomena involved in various psychopathological states. Phenomenology of schizophrenia, historical overview. Emil Kraepelin, this was the name which is very much present in most of the textbooks. He translated morals dominance precox into dementia precox. Whenever we are not able to justify schizophrenia on the basis of DSM-5 or ICD-11, we say that, well, I have a precox feeling in this patient. That precox feeling was the feeling which was described by Kraepelin, and he called it dementia precox. So the name of schizophrenia was not schizophrenia, but dementia precox. And the most common theme of it was cognitive decline. So people start having cognitive dysfunction, an early onset of cognitive dysfunctioning, which was again early onset means around the age of 20, and that was called as Emil Kraepelin called it dementia precox. So dementia precox and Emil Kraepelin are synonymously used. After Kraepelin, Eugene Bleuler coined the term schizophrenia to mean splitting of the psychic functions. Bleuler made a distinction between fundamental and accessory symptoms of schizophrenia. Eugene Bleuler actually was the first person who named schizophrenia. Before that, Emil Kraepelin and Morel, they called it dementia precox. After Eugene Bleuler, which was approximately around 1930s, that he gave the name schizophrenia. But schizophrenia as a diagnostic entity was not having positive, negative symptoms and other symptoms. It was actually more said that it's splitting of a personality, which of course is not correct now that we believe it. Splitting of a personality or the psychic functions is different than what actually now schizophrenia is diagnosed as. The fundamental symptoms of Bleuler, which were also designated as 4As. Now, these 4As are important again, theoretical point of view, exam question. What are Bleuler's 4As of schizophrenia? 1, association. 2, affective disturbance. 3, autism, and 4, ambivalence. Now, these terms like autism is not now used for any kind of schizophrenia, but historically, association, autism, affective disturbance, and ambivalence, 4As were Bleuler's diagnostic criteria for schizophrenia. Association means thoughts disturbance, especially loosening of association. Affective disturbance means no effect, blunting or flattening. Autism means there was a fixation and person was living in his own inner self, inner fantasy world. And ambivalence is negativism. So if you ask the person to extend the hand, they were withdrawing it. When you ask the person to stand up, he keeps on sitting or maybe lie down. So ambivalence is the again the plus and minus situation associated with any other thought and gesture. So association, affective component, autism, and ambivalence are 4 A's of Eugene Bleuler, and this was the first diagnostic criteria given to this disorder. Later on, Bleuler viewed some of the most frequent and striking symptoms were accessory symptoms, which were secondary, not primary symptoms. These included hallucinations, delusions, catatonia, and abnormal behavior. So the primary criteria for Bleuler were 4 A's: association, affective, autism, and ambivalence. And secondary criteria of Bleuler was hallucinations, delusions, catatonia, and abnormal behavior. Now that it's been reversed, so now we say the first rank symptoms are hallucinations and delusions, and the affective flattening, loosening of association are actually the secondary. Previously, they were primary or secondary. Bleuler, the other way around. Adolf Meyer saw schizophrenia and other mental disorders as reaction to life stress, and he called these schizophreniform reactions. So whatever the way I am reacting to the society, I am reacting at home, that was called schizophreniform reaction. Adolf Meyer used the term schizophreniform. Now, this term is used in a very different way nowadays. Harry Stack Sullivan emphasized social isolation as a cause and a symptom of schizophrenia. So people who used to live alone, they were again on the sideline, they were walking on the streets, homeless. Harry Stack Sullivan felt that because of that isolation, there were some symptoms of schizophrenia. But again, synonymous. Symptoms of schizophrenia, isolation, and isolation leading to schizophrenia. Wolfgang Blankenberg said this is a loss of common sense. Now, this is very tricky because common sense is probably the most uncommon sense. That's what we believe. And Wolfgang Blankenberg said that losing common sense is schizophrenia. Ernest Kretschmer, historically, again, these are mostly German and French names because most of the time, those were the places where these disorders were studied back in 1930s and 50s up to that 22 decades time period, mostly French and German terminologies. So Ernest Kretschmer compiled data to support the idea that schizophrenia occur more in persons with asthenic body build. There were 3 kinds of body build: asthenic, athletic, and picnic. Picnic is hefty, mota, and athletic, patla, muscular, or asthenic was thin and fragile. So he associated, Ernest Kretschmer associated asthenic body type to be associated with schizophrenia. Even now, when you see people who are suffering from schizophrenia, they don't have the muscle mass. Actually, the mass is flaccid and they are usually thin people, usually because of multiple reasons: lack of appetite, lack of diet, inability to eat because of their paranoid symptoms or whatever. But initially, they thought that asthenic body build is associated with schizophrenia. All people with asthenic build could develop schizophrenia, and he actually collected data first time around it. Gabriel Langfeld proposed a distinction between true schizophrenia and having insidious onset, derealization, depersonalization, autism, emotional blunting, and poor outcome from schizophreniform states. Now, what is this? Gabriel Langfeld believed that, okay, true schizophrenia means other symptoms, but if somebody develops the symptoms over the period of months or years, this is called insidious onset, and this was related to blunting of effect and poor outcome, and he called it schizophreniform states. Eugene Minkowski said loss of vital contact with reality. Now, if you talk about insight these days, this concept was given by Eugene Minkowski, that you lose the insight, loss of vital contact with reality. And then he also mentioned compensatory morbid rationalism, hypertrophy of intellectualism. So when you remain isolated, keep thinking, you behave like an intellectual person, but actually it's hypertrophied intellectualism. So you are not actually intellectual, but pseudo-intellectual, which appears to be intellectual, but actually it's not intellectual. And he called it pragmatic dementia. So Eugene Minkowski said hypertrophy intellect. All of these terms, whatever I'm telling you now, again, they are very significant historically and led to the diagnostic criteria DSM-5 and ICD-11. They are all based on these. Later on, when we investigated, when we had the data, when we were more clear about the pathology, we were more clear about the diagnosis. Kurt Schneider. Now, this was the breakthrough in the schizophrenia. Kurt Schneider tried to make the diagnosis more reliable by identifying a group of symptoms characteristic of schizophrenia but rare in any other disorder. So those symptoms which when we say that, okay, fine, now this person is having this symptom, this is definitely schizophrenia. This was first given by Kurt Schneider. And Kurt Schneider actually gave a proper diagnostic criteria. Just for a break, मौसम हालात देख गिरिया बेबाक देख तारीख मरकज में चढ़ता हुस्न आफ्ताब देख उनके आने से तो मुझ में रंगीनी शबाब देख मफहूम हिजरे यार क्या है चमन बेगुलाब देख हुसूल शीरी की लगन में हिम्मत फरहाद देख जानते हो इश्क क्या है पिसरे बू तुराब देख पेचीदा सवालात का है मुख्तसर जवाब देख FCPS psychiatry. Phenomenology of schizophrenia. So Schneider gave the first rank symptoms and second rank symptoms. These were the symptoms or the diagnosis of schizophrenia on the basis of the historical perspective which I mentioned to you earlier. Now Schneider said that the first rank symptoms, which includes audible thoughts, voices arguing or discussing or both, voices commenting, somatic passivity experiences, thought withdrawal, insertion, and other experiences of influenced thought, thought broadcasting, delusional perceptions, and all other experiences involving made volition, made affects, and made impulses. Now, this is important. This is first rank symptoms of Schneider for the diagnosis of schizophrenia. Made volition, somebody wants me to do something. Made affects, somebody is affecting my mind. Made impulses, somebody make me do things which I don't want to do. So all of these things were characterized together as first rank symptom of schizophrenia. In the second rank symptoms, like other disorders of perception, so if I start feeling that insects are crawling on my body, sudden delusional ideas, like I start feeling that the weather outside is bad because, again, God don't want me to go outside. Perplexity, it's a confusion state which for people feel that I am ambivalent. So the ambivalent and perplexity are different, but they are considered synonymous here. Depressive and euphoric mood changes, feeling of emotional impoverishment, lack of emotional expression, several other abnormal experiences. Now, these Schneider's criteria of schizophrenia, first rank symptoms and second rank symptoms, were actually the key. And after that, the diagnostic criteria kept on improving. And now we have DSM-5 and ICD criteria. But these are important symptoms. Carl Kleist looked for association between brain pathology and different subtypes of psychotic illnesses. Lionheart distinguished schizophrenia from cycloid psychosis. He divided schizophrenia into two groups: one, systematic schizophrenia, and two, non systematic schizophrenia. Now, Lionheart said that if the person is having catatonic symptoms, hebephrenia, or paraphrenia, this is systemic schizophrenia. And if a person is having affect laden paraphrenia, schizophasia, and periodic catatonia, this is non systemic schizophrenia. Well, these things are still considered somewhat in the modern psychopathology, but not in these terms. T.J. Crowe. Now, the Crowe was a person who actually did a lot of study on schizophrenia. And then he proposed a classification of schizophrenia of patients into type 1 and type 2 on the basis of the presence of absence of positive symptoms. So type 1 schizophrenia, where there are positive symptoms, type 2 schizophrenia, when there were negative symptoms. Carpenter coined the term deficit schizophrenia, for especially to those negative symptoms that are present as enduring traits. Deficit symptoms may be present during and in between the episodes of exacerbation of positive symptoms, regardless of patient's medication status. Presently, schizophrenia is diagnosed by using classification systems like DSM and ICD. These have the advantage of international comparability, but many have criticized them for trading off validity for the sake of reliability and were conceived as gatekeepers, that is, minimum numbers of checklist symptoms needed to make a diagnosis. So there is a lot of debate about it. When we used DSM-5, when we used ICD-11, we actually do the checkbox. If this is present, tick. If this is present, tick. If this is present, tick. Diagnosis, schizophrenia. And lots of psychiatrists, especially the old school thought psychiatrists, they don't believe in it. They say that we should not go for the checklist. But unfortunately, whenever you are giving the exam, you have to do the checklist. If the symptom checklist is missing and you say that this is schizophrenia, you may be able to justify your diagnosis on the basis of the history that I have just told you, but you won't be able to make the diagnosis scientifically to satisfy the examiner. That's the tricky situation. Thought disorders found in schizophrenia: disorder of the form of thinking, the formal thought disorder, predominantly disturbance of conceptual or abstract thinking and association between consecutive thoughts. So if I'm talking to you, there is a chain of thought that is coming out of my mind in the form of words, and I'm expressing it to you. One after the other, the thought keeps on coming, and I'm expressing it. So there is a relationship between my thoughts and what are coming after that. So I keep on making sense out of it. If I start talking in this presentation from last slide to the first slide to 31st slide to the 21st slide, maybe you won't be able to make sense out of it. So basically, whenever we say form of thought or formal thought disorder, the link between one thought coming after another in the form of words matter the most. Cameron grouped thought disorganization symptom into 4 groups. 1, incoordination. So that whenever I am speaking, as my thoughts are coming out, there is no coordination in between them. Interpenetration of themes. So I'm talking about schizophrenia, and for next 40 minutes, I'll keep on talking about schizophrenia and nothing more than that. But I do have interpenetration when I put some themes like poetry, ghazal, sher, etc., things are different. Fragmentation and over-inclusion. He introduced 2 terms, asyndesis and metonyms. Asyndesis, loss of adequate connection between subsequent thoughts. Asyndesis. इस वक्त I am expressing my thoughts and emotions, they are connecting and coming out in a theme. This is asyndesis. Metonyms, imprecise approximation and substitution of words or phrases. The words that I am able to express my thoughts and emotion in this presentation, they are mixed. So they don't make sense out of it. Again, this is formal thought disorder. I have missed one important name historically here, probably even I missed at that time. That was Jasper. Jasper actually did a lot of work on formal thought disorder. Bloiler regarded schizophrenia as a disorder of association, as I mentioned earlier. He believed this incompleteness or disorganization of ideas to have resulted from condensation, displacement, and misuse of symbols. Goldstein differentiated concrete thinking of patients with schizophrenia from those with coarse brain damage, as in the formal patient's fund of words remains intact. So in schizophrenia, the thought which are coming out of the process, they actually lose the contact with each other, but the person is able to comprehend properly. But in dementia, where again people forget, they usually give up pauses and they forget about the things. So Goldstein differentiated that. Schneider isolated 5 types of FTDs. 1, derailment, substitution, omission, fusion, and driveling. Now, these 5 things are present. अगर आप फिश की बुक पढ़ें, phenomenology की, उसमें भी ये mention है. आमतौर पे लोग इसमें confuse होते हैं. I won't focus more on this slide, but you should remember that derailment is still a valid terminology that can be used in diagnosis of schizophrenia. Some commonly encountered FTDs in schizophrenia: irrelevance, incoherence, derailment, loosening of association, word salad, neologism, illogical thinking, and tangentiality. All of these terms are still valid and used as diagnostic criteria for schizophrenia. I'm sorry, this is quite boring and dull topic, but it is important for you to know all of this. Disorders of the flow or stream of thought. I should have explained all of these things in more detail, but unfortunately it's a lengthier presentation. I won't be able to finish it in time, so I'm running a little bit faster. If you won't be able to understand it, we'll do it again. Disorders of tempo, flight of ideas, inhibition or retardation thinking, and circumstantiality. Disorders of continuity of thinking, perseveration and thought blocking. Perseveration when we keep repeating one thing time and again, and thought blocking when you are absolutely blank, where is the thought? And you start from where you disconnected. So in between there is a gap, there is an empty space. I have uttered the word, then I am quiet, and then I start uttering the same sequence of words which I have uttered before. The connection is there, but in between there is a gap. This is thought blocking. Again, I won't go for whole of it because again we have to finish the presentation. मैं तो खुदा के साथ हूँ, तुम किसके साथ हो? हर लम्हा ला के साथ हूँ, तुम किसके साथ हो? तुम भी तो आज मुझसे करो कुछ सुखन के, मैं नफिए अना के साथ हूँ, तुम किसके साथ हो? I don't know. Okay, disorders of possession of thought, obsessions and compulsions, thought alienation experiences, thought insertion, thought broadcasting, thought withdrawal, or deprivation. Now, we don't use word deprivation now anymore, but it was used historically. Disorders of content of thinking, delusions, ideas, overvalued ideas, depending upon the degree of the conviction upon the falsely held beliefs. Delusions are false, unshakable belief which cannot be corrected by any means of reasoning and are not keeping the patient's socio-cultural background. For phenomenologically point of view, delusions are classified into primary delusions and secondary delusions. You all know that. Primary delusions, ultimately and ununderstandable, occurs de novo and does not allow empathy. Conrad termed epiphany. Conrad ने इसको epiphany ना, primary delusions. Three types were described by Schneider: delusional mood, delusional idea, and delusional perception. Well, there was one more added into it: delusional memory. Not by Schneider, but now. So primary delusion, if a person is having a delusional mood, delusional perception, or delusional memory, any one of them, diagnosis is schizophrenia, even in DSM-5 and ICD-11. Secondary delusions, understandable in context of other morbid experiences, physical or psychological state. Some suggest projection in the formation. Freud suggested latent homosexuality. Of course, this is not true, but again, secondary delusions, when we have paranoid delusions, persecutory delusions, religious delusions, delusions of grandiosity, blah, blah. They are all secondary delusions. Depending upon the content of the delusions, delusions are delusion of persecution, jealousy, love, control, infidelity, somatic, hypochondriacal, and grandeur. Grandeur sometimes in paranoid schizophrenia as well. I won't go into the description of these delusions. Capgras, an uncommon syndrome in which the patient believes that a person to whom they are close, usually a family member, has been replaced by an exact double. Intermetamorphosis. Intermetamorphosis, characterized by delusion that people have swapped identities while maintaining the same appearance. शक्ल वही है, आदमी कोई और है. Involves a false recognition of both appearance and identity. Furgoli delusion. Now, Furgoli there is a rare disorder in which person holds a delusional belief that different people are in fact a single person who changes appearances or is in disguise. The syndrome may be related to brain lesion and is often of a paranoid nature, with the delusional person believing themselves persecuted by the person they believe is in disguise. The condition is named after the Italian actor Leopoldo Furgoli, who was renowned for his ability to make quick changes of appearances during his stage act. Disorders of speech, stammering or stuttering, occasionally in acute schizophrenia. Now, acute and chronic schizophrenia are synonymous with type 1 and type 2 schizophrenia as well. Mutism. In catatonic stupor, guarded paranoid patients, and also in drug-induced akinesia, mutism is the presentation. Vorberedern, now I am not able to pronounce it properly because I don't know German too much, or talking past the point. This is seen in old hebephrenic schizophrenia. Neologism in catatonic and hebephrenic schizophrenia. Speech confusion in chronic schizophrenia. Echolalia in catatonic patients. Alogia in negative symptom schizophrenia. Coporophasia, involuntary use of obscenities and vulgar language, and poverty or pressure of speech. Now, all of these symptoms that I'm describing, historically, they are, again, some of them are still used, some of them are obsoleted. Sensory distortion includes changing in intensity, quality, and spatial form. So, hyperesthesia, hyperesthesia, xanthopsia, chloropsia, erythropsia, everything appears red. Spatial form, dysmegalopsia, which means things appear bigger. Micropsia, things appear smaller. Macropsia, things appear bigger. Now, dysmegalopsia and macropsia are different in a way that in macropsia, everything is bigger, and dysmegalopsia, the things appear bigger from one end and smaller at the other end. So मुंह बड़ा हो जाएगा, जिस्म छोटा हो जाएगा. These are rarely found in schizophrenia and suggested to be involved in formation of neurotic symptoms like hypochondriacal dysmorphic symptoms. Now, this was another diagnosis. When we were doing psychiatry, this diagnosis was very much prevalent. Dysmorphophobia, and again, a delusional disorder. Disorders of experience of time, sense of slowing, fastening, also considered as sensory distortions in schizophrenia. Sensory deceptions, illusions, rare in schizophrenia. Pareidolia, vivid illusions without patient making any efforts due to excessive fantasy thinking and vivid visual imagery seen in schizophrenia with excessive autistic thinking, sameness, time and again, sameness. यूं ना झांको गरीब के दिल में, यहाँ हसरतें बेलबास रहती हैं. Probably true for most of us. Hallucinations, perception occurring without the presence of corresponding object or sensory field. Now, this is the name that I told you earlier, Jasper. Jasper did a lot of work on schizophrenia and he coined multiple terms. Jasper distinguished between true hallucinations and pseudo hallucinations by person's experience of hallucinatory object being located in objective or subjective space respectively. So when we say this person is hallucinating, actually it is a, again, objective space. बाहर से कानों में आवाजें आती. And then when the person says true pseudo hallucination, means they are inside my mind, there are nothing as such objective about it, a subjective experience. Now, objective space and voices coming through it are schizophrenia. Subjective space inside the head is not usually schizophrenia. Pseudo hallucination was given by Hegel. Earlier it was known as pale hallucination or aperceptive hallucination. So actually they are not hallucinations, but they appear like an hallucination, and this term was given by Hegel while seeing the patients. Hillers argued schizophrenic hallucinations to be mental images based on a patient's thought or affect rather than true perceptions. For example, a schizophrenia may be having persecutory delusion, can report that his food tasted of arsenic, which in fact is tasteless and which he never tasted before. So this is the comparison. Hallucinations can be a result of intense emotions, suggestion of disorder of sense organs, sensory deprivation, CNS disorders, and several other causes. Schizophrenia hallucinations are auditory, again, less on other modalities. I will skip this because I think you all know about it. Schizophrenia auditory hallucinations could be thought echo, third person auditory hallucination, running commentary, or internal hallucination. Now there are two types, extracampine hallucination and functional hallucination, and there are also again description associated with it. Unlike normal people, many schizophrenia are quite undisturbed by their inability to describe the direction and the sex of the speaker of those voices. These have variable effects on the patient's behavior, some quite unconcerned and others totally disturbed. So this is a variation. So there are people who have hallucinations and they are fine with it. And there are people who have hallucinations and they're grossly disturbed, suicidal, and even homicidal. Visual hallucinations are usually rare in schizophrenia. So if I feel that my patient is having visual hallucination, I will definitely not put my differential diagnosis of schizophrenia as number one. Tactile, gustatory, olfactory, and somatic hallucinations are not common in schizophrenia. And unfortunately, again, historically, if these hallucinations are there, tactile, gustatory, olfactory, or somatic, then we make the diagnosis in differential diagnosis other diagnosis first and then schizophrenia later. Synesthetic hallucination can occur in schizophrenia, for example, burning in brain. Now, brain cannot burn. मेरा दिन भेजा दही कर दिया. Pushing sensation in blood vessels or cutting sensation in bone marrow. Now, I cannot have any sensation in the bone marrow. Of course, I can have pain in the bones because of the nerves in the periosteum, but I cannot have a cutting sensation in the bone marrow. That is commonly again seen. Disorders of mood and affect, inadequacy, incongruity is classical. Flat, shallow, blunt, anhedonia, apathy is again relatively there. These inadequacies or blunting effect was termed as parathymia by Bloiler. Others are overtly active and show inappropriate emotional expression. Reactivity is present and range may be labile called affective incontinence. This term is not used anymore. Affective incontinence or compulsive affect and seen in hebephrenic schizophrenia. Silly, euphoria, querulous ill humor, careless indifference, and autistic depression. Now, these are all the terms which were used in the past. They are not used anymore. But again, if somebody says these kind of words like querulous ill humor, don't panic. It's querulous ill humor is associated with schizophrenia historically. Schizophrenia include perplexity, overwhelming, ambivalence, and a sense of isolation and depression. These abnormal emotional expressions in schizophrenia does not allow empathy or rapport to establish. In addition, dissociation of affect, affectionless personality, and effects of anxiety may also lead to diagnostic dilemma. Disorders of motor behavior. The name here is Carl Baum. Carl Baum. Carl Baum was the person who actually elicited soft neurological signs. So the neurological signs that were seen now as called as soft neurological signs are actually the term was coined by Carl Baum. Carl Ludwig Carl Baum. And this is catatonia. Several others consider them to be the result of patients' conscious or unconscious attitudes, stereotypes, symbolic meanings, etc. कोई समझे तो एक बात कहूं, इश्क तौफीक है, गुनाह नहीं. Well, most of the people believe that ishq is a sin actually. So this is a simple term. कोई समझे तो एक बात कहूं, इश्क तौफीक है, गुनाह नहीं. I hope I am not getting too far away. Okay, अगर समझ आनी बंद हो जाए, जो कि मुझे पता है कि मुश्किल है, just stop me. Some common motor abnormalities in schizophrenia are decrease in psychomotor activity, increase in psychomotor activity, mutism, rigidity, posturing, negativism, automatic obedience, vexiflexibility, psychological pillow, ambitendance, ecopraxia, echolalia, tics, mannerism, stereotypy, and facial grimacing. This was the term which was called Schockkrampf. Well, again, historically. Then there is depersonalization, derealization, then there is a conceptual or abstract thinking abnormalities. We don't go for abstract thinking assessment anymore on mental state examination. It was long time abolished, probably more than 30 years ago. People stopped doing the abstract thinking because they believe that this is not a diagnostic test to differentiate between organic schizophrenia and other disorders. So it was actually removed. But historically, it was considered to be one of the symptoms of schizophrenia where person loses abstract thinking. Like, I don't know what is behind this wall. So cognitively, I can process it. Behind this wall is my living area where there is a sofa and a picture. But again, in schizophrenia won't be able to process that. But this abstract thinking is actually not pathognomic of schizophrenia, so it was removed. Then other signs and symptoms. This is important. This is very important, and this is historically there. Lack of proper personal hygiene. I have seen schizophrenia people who have very good hygiene. Decreased work functioning, diminished social interaction, decreased sleep and oral intake, impulsivity and violent behaviors, vague somatic complaints, localizing hard or non-localizing soft neurological signs, dysdiadochokinesia, asterognosis, primitive reflexes, diminished dexterity sides when you have to distinguish between right and left, abnormalities of motor tones and movements. Again, all of these are seen in schizophrenia. And suicide in schizophrenia. People with schizophrenia attempt suicide much more often than people in general population. It is about 10%. So if I'm seeing 100 patients of schizophrenia, of them 10 have attempted suicide in their lifetime. It is hard to predict which people with schizophrenia are prone to suicide, but if someone talks about or tries to commit suicide, professional help should be given right away. Last few slides, differential diagnosis. Functional psychotic disorders. Now, these are terms historically used, but now in DSM-5, they are mixed. Schizoaffective, delusional disorder, brief reactive psychosis, postpartum psychosis, post-psychotic depression, side effects of antipsychotics add diagnostic dilemma, and personality disorder, schizotypal and schizoid. मिले तो मिल लिए बिछड़े तो याद भी न रहे, मिले तो मिल लिए बिछड़े तो याद भी न रहे, ताल्लुकात में ऐसी रवा रवी भी ना हो. So मिले तो मोहब्बत से मिले वरना मत मिले. Now, course of schizophrenia. There is a pre-morbid phase, there is a prodromal phase, there is a pre-psychotic state, there is psychosis, and there is remission. People say that at the time when there is a pre-morbid phase to a full-blown psychosis, it takes usually 4 to 5 years. So a person around the age of 12 and 13 will start having some symptoms which will be in a pre-morbid phase of schizophrenia, and it will be full-blown schizophrenia at the age of 19. So there is a time frame of 4 to 5 years. Now, various studies quote various times. This is just one idea that sometimes it may take longer to have schizophrenia than the prodromal state. About 1/4 of those who experience an episode of schizophrenia recover completely. So around 33%, no, around 25% recover completely. 1/4 experience recurrent episodes, but often with only minimal impairment of functioning. The other 1/2 of schizophrenia becomes chronic mental illness, and the ability to function normally in society may be severely impaired. Now, there is a change in these scenarios. This was 20 years ago. Now, people say less than 10% of the patients of schizophrenia without treatment, they ever recover. Less than 10%. Without medication, probably none of them recover. So the data is changing, and approximately 80% of the patients do respond to some kind of treatment. There is a small percentage of about 5% who is not responsive to any kind of treatment, and there we have to go for other structural treatments as well. So look, Compi 1980, complete remission in 27%. ICMR reports 27%. ICD-10 gives continuous episodic with stable episodic remission, incomplete remission, and complete remission. These are the terms given in ICD-10. I have to update these slides for ICD-11 and DSM-5. Now, this is a common question which is asked in the exam. The good prognostic factors and the poor prognostic factors of schizophrenia. ये 12 याद कर लें, ये रटने हैं. Good prognostic factors: abrupt or acute onset less than 35 years of age, presence of a stressor, catatonic type, good premorbid adjustment, presence of depression, premorbid positive symptoms, family history of mood disorder, female sex, good social support, normal cranial CT scan. These are good prognostic factors. Poor prognostic factors: insidious onset, slow and gradual. Onset after the age of 20. Absence of stressor, disorganized, simple, undifferentiated. Poor premorbid adjustment, chronic course, absence of depression, predominant negative symptoms, family history of schizophrenia, male sex, poor social support, and ventricular enlargement on a CT scan, then you say that it's a poor prognosis. बहुत अजीब हैं ये बंदिशें मोहब्बत की, ना इसने कैद में रखा ना हम फरार हुए. Thank you very much. This was again a tricky presentation, but I finished it in an hour. So I hope if you'll be able to go through it back again and listen to it, most of the terminologies that I have said, you'll be able to understand them. Any question?